Um, so
Yeah.
good morning.
Hi, Kimberly.
Hello, Dr. K. So
Hi.
I will
Kim-
continue to admit people into the room as they enter in. So welcome everybody. We are so pleased that you are here. It's March, it's Endometriosis Awareness Month, and there's so much going on. But amidst everything, I really wanted to create this opportunity for us to be joined with expert endometriosis excision specialist Dr. Kanayama from the New York Endometriosis Center to
Hi.
shed some light on some of the maybe misconceptions or unknown things when it comes to endo and adeno surgery. I actually have a bunch of pre-submitted questions. So if you're on and you've pre-submitted questions through the Instagram story that I created, thank you so much. We will be going through some of them. Feel free to use the chat feature. So you can type in the chat and submit your questions, which we will get to. So I'd love to get the ball rolling, Dr. K, if that's good with you.
Yes.
Yeah. I'm just letting you know a big thunderstorm is coming here. So if you struggle to hear me, let me know and I'll just talk closer to my mic. But can you just confirm that you can hear me okay, Dr. K?
Yes, I can hear you okay. Do you hear me?
Yeah. Perfect. All right, everybody. Like I said, feel free to use the chat. I'd love for this to be interactive also. And for those of you who aren't able to join us today, it's wonderful that you have registered because you hopefully will be watching this on replay. So the first question I want to ask you, Dr. K, is does surgery get harder after previous ablation due to scar tissue?
Yes, in general, yes. Because of ablation surgery, basically they burn the tissue. So if this is endo here, like a laser or any type of ablation burning method, it's just burn the tissue only. Without really excising endometriosis. So after the burning energy is used, this tissue become much more sticky to stick together.
Mhm.
So ablation surgery actually causes good amount of adhesions because I operated on the patient after ablation surgery. So I have to release all of the scar tissue adhesion caused by ablation method.
Okay, so yes, in essence, it does get harder because
Yes.
the ablation causes a lot of scar tissue. This is an interesting question submitted by someone who's actually a medical professional herself, and it is why do you think most surgeons nowadays use the robot for endometriosis surgery?
That's a good question. I don't know why, but because of it, I think it is. Um, I cannot really speak for other surgeon why they choose to use Da Vinci robot. Um, but I prefer this is like this robotic surgery happening about 20, almost 25 years. I think it's like 2002. And it is, I think it is um, accepted by the community, easier to operate. Um, but to answer to that specific question, um, I I just don't know,
Just
to
don't know.
be honest with you.
Okay. Um, what effects does endo excision surgery have on hormones? Do we know?
Excision surgery and hormone. Um, Endometriosis excision not directly change the hormonal level. Um, However, estrogen, as many of the endo sisters know, endometriosis is producing its own estrogen. So endometriosis is not same as endometrial tissue. Like a normal endometrial tissue does not produce any estrogen, but endometriosis create its own estrogen. So direct effect of complete excision of endometriosis actually decrease estrogen production, which is caused by the endometriosis.
That's actually a really good question. Yeah, because and I always use the analogy like they're their own little factories that produce their own
Yes,
and fuel and they fuel themselves. So you're breaking that cycle by
exactly.
by
Yes.
literally removing themselves out of their own food.
And also, making another comment, adenomyosis tissue is not same as endometrial tissue.
Hmm.
So again, endometrial tissue cannot produce its own estrogen, but adenomyosis tissue research data showing it can create its own estrogen locally
Yeah.
without any ovary. Yes.
Yeah, it's fascinating. It converts other hormones and uses specific enzymes to convert, for example, like androgens, your more male sex hormones,
Right.
testosterone into estrogens. Fascinating, really. This is an interesting question. Now, if someone has a small endometrioma, is it worth
Hmm.
waiting to do surgery while focusing on other factors like PT and nutrition? And I know it's a very unique, the answer would be related to the individual itself, themselves, and what their symptoms are, their fertility goals, and etc. But
Hmm.
what is your
Hmm.
opinion on this?
Um, this question, I cannot really make a generalized statement because of each patient is so different and unique. So I need to know history of specific patient presented with chocolate cyst endometrioma and what type of treatment she has been done before, if she has done any surgery, any excision surgery, and what kind of uh, medical treatment she's receiving. And
Yeah.
also, if she wants to get rid of her pain, her main concern is pelvic pain and a symptom of endometriosis, or her main concern is try to get pregnant.
Mm-hmm.
So all of this area need to be completely assessed, by me, by the doctor, and really, we really need to come up with a best strategy how to get A to B. So, so this is a type of question. It needs to be totally individualized.
Yeah, all those things need to be taken into consideration. And someone submitted this question. I know she can't join today because she's on the other side of the world and it's the middle of the night, but she wanted to know whether it's possible to remove endometriosis without affecting the functionality of the endo-affected area or organ.
Yes, it is possible. So that's why I use haptic technique. And haptic technique means, um, say this is my scissors. My hand is holding the scissors. So when I say like this is endometriosis, when I touch the endo here,
Mm-hmm.
this very delicate texture of the tissue, my hand knows I have done so many surgery in my life, thousands of cases. So my right hand already knows what texture is endometriosis, and what texture is endofibrotic tissue, and the surrounding fibrotic area, and what texture is normal tissue, separating this disease area and normal area.
Mm-hmm.
Do you
Mm-hmm.
understand me? So by using a haptic technique, I can really differentiate borderline between these two.
Mm-hmm.
So I can cut the disease portion and keep the normal tissue intact.
Mm-hmm. Mm-hmm.
So that's a way how to excise the endometriosis without damaging normal organ, normal tissue, which is right next to endometriosis.
And I think, when we think about cases where we see quite large endometriomas and the effect that um, an attempted removal of it could potentially have
Mhm.
on ovarian function and fertility, it's really important to ensure that um, someone knows exactly what they're doing. As
Yes, so this is a very good question. Endometrioma is very sticky. Like, if you operate on the chocolate cyst, it is not easy surgery because of chocolate cyst endometrioma is highly fibrotic, inflammatory, and it is so. intimately sticking to the ovarian cortex of normal ovary.
Mhm.
So that's why if your doctor use Da Vinci robot, they cannot feel anything. So they operated over there, far away from the patient. Then they try to peel off endometriosis cyst from ovarian cortex by the vision only.
Mhm.
But if you cannot feel anything, it is very easy to pull too hard,
Mm.
then destroy normal ovarian cortex. Then the patient ovarian reserve going to be decreased by non-haptic surgery like a Da Vinci robot. So that's why surgeon really need to feel texture of the disease and also texture of the normal ovary in order to save ovary. And so like I have several patients I operated on 29 centimeter chocolate cyst. 95% of patient ovary is destroyed. But I still save the ovary because of I I find that division line.
Yeah.
And this division line is so sensitively need to be touched.
Hmm.
Then you can save the good amount of ovary for the patient to become pregnant.
Wow. Wow. 29 centimeter.
Yes.
Oh, yes. Wow.
And
You,
this patient become pregnant after this.
oh, that's amazing. Wow.
Yes. So
That's
nothing is impossible. You can do it.
that's wild. Okay, and on the topic of pregnancy, someone's asked, how quickly can you conceive after surgery? What's like the timeline to start trying after surgery?
Oh, good question. Again, this is more like an individualized questions. So if I detect stage one, stage two, or relatively early phase of endometriosis, my patient can become pregnant 1 month after surgery. And but if I'm really doing a DIE, deeply infiltrating endometriosis, and also adenomyosis excision, also stage four,
Mm,
very deep endometriosis. And this deep cut area need to be healed by layer by layer. And in order to heal completely, it takes more time. So for those patients, I will again individualize after the surgery.
mm.
But some patients try to become pregnant 6 weeks, 6, 7 weeks after the surgery. Some patients try to become pregnant 2 months after surgery. Some patient I will wait up to 10 weeks after surgery.
Wow, to me that seems pretty still relatively fresh after such big surgery. I guess it depends on how they're feeling as well.
Depends on the patient, yes.
Yeah.
And some patient I ask them to wait for 3 months.
Yeah. Yeah.
So, so it's up. So that's why after my surgery, I need to see my patient. I need to do my ultrasound to see how well it is healed, how much healing is already happening at how many weeks. Then I can individualize activity level and the chance of timing to become pregnant.
Yeah.
So that's kind of like my approach.
Wonderful. Now, there is a question here, and I'm thinking maybe due to the, limited characters on Instagram, the whole question wasn't written out properly, but it is a good question. And I'm thinking she might be asking, do you have to get a C-section when you give birth after getting endo surgery if you have adenomyosis more on the severe end?
Okay, so is this means C-section
Birth,
to
deliver a
deliver
baby.
the
So
baby,
somebody
deliver the baby.
has severe adenomyosis, has become pregnant post endo excision. Does it necessarily mean she has to get a C-section to deliver her baby?
No, not necessary. And the number one, if patient doesn't have a adenomyosis, uh, all of my endo patient does not require a C-section because of the surgery. They can deliver naturally, including stage four and DIE and ovarian chocolate cyst, and also including adenomyosis patient. There's type of adenomyosis which is combined with endometriosis like this, like
Mm-hmm.
a one piece.
Mm.
So backside of the uterus is attached to the rectosigmoid colon, and the rectovaginal system is totally invaded, not by endo, but adenomyosis.
Oh,
So
wow.
these are the type of patient I do precisely laparoscopic without opening up.
Okay.
Then my laparoscopic excision, I can still feel every layer of adenomyosis. Then I can slice this off, then get to the root of the disease, then
Yeah.
completely clean up. And these are the patients, they can deliver completely naturally and, no C-section. And
Gotcha.
or another case, I have several patients, they have a diffuse adenomyosis, almost like uh, 50% of the uterus is covered by diffuse adenomyosis. And I can still cut this by laparoscopically, and this patient become pregnant and deliver vaginally.
That's wonderful.
So doesn't require C-section. But in the case of most difficult adenomyosis patient, sometimes I need to remove 100 pieces of adenomyosis, 200 pieces of adenomyosis
Wow.
from the uterus. Then after that, I have to put so many stitch, layer by layer. Sometimes I need to put 100 stitch to create a new uterus.
Wow.
And that kind of patient requires C-section
Wow.
when they deliver the baby, yes.
Wow. Wow.
So
That's
everybody is different, but
yeah.
they can still become pregnant and they can still deliver a baby.
Wonderful. That is encouraging to hear. Um, it is very encouraging to hear. So this is actually a really good question, and it may seem obvious to, to doctors who perform surgeries day in, day out, but how can you see if there is endo in other locations of the body during surgery?
Oh, okay. So, so when I do laparoscopy, of course, I put the camera through the belly button.
Mm-hmm.
Then, uh, unlike Da Vinci robot is actually, you have to understand robot metal arm. This is robot machine holding the camera.
Mm-hmm.
And, but in my laparoscopy, I am the one holding it. My right hand right here is holding the camera.
Mm-hmm.
So literally when I put the camera inside, I will meticulously investigate up to the diaphragm lung and down to this entire abdominal cavity
Mm-hmm.
and down to the anus area.
Mm-hmm.
So I can kind of like hold my camera and I can move my camera to every different directions. So say like this is my camera, this is endometriosis here. So I can move this camera quite fast, so many different angles.
Mm-hmm.
Then I can see even very subtle endometriosis I can detect by this visual inspection. Then once endo was detected right here, then I can use my haptic technique. Then I can feel how deep this endometriosis is going inside. So these are the type of technique combination which is very important for my excision surgery. And that's the reason why I find so many endo from my patient. Sometimes 50 spots, sometimes 100 spots, sometimes 250 spots.
Wow. Yeah,
You
because
can detect so many.
you're looking and feeling.
Mhm.
Yeah.
Look and feeling. And also most important thing is my hand is holding the camera.
Okay.
So if robot is holding the camera, robot can move by zoom in and the machine can move slowly to go up, go down, left and right. But this doesn't have the same flexibility of my hand, how quickly move camera and how light reflection. 20 degrees light reflection, 90 degrees, 120 degrees light reflection. All of this light reflection really expose different shape and reflection of the endometriosis, which is very tiny, pinpointed one.
Wow. It's really intricate, isn't it? It's like an art.
It is very delicate, yes, intricate, yes.
Yeah. Okay, those are all wonderful questions. Now, this may sound a little bit general, but what would you say is the first step to take if you feel like you may have endometriosis?
Um, I think it's important to go to specialist.
Mm-hmm.
Um, I'm not criticizing OBGYN doctor, but I'm telling you my in my medical school, almost like nobody really teach me endometriosis in med school. It's
Wow.
very, very ignored, completely ignored. And I went to OBGYN residency at the Mayo Clinic. Even at the Mayo Clinic, endometriosis is not even emphasized. It's just very short period of teaching only. Then
Wow.
I talked to my professor. I want to study endometriosis. I want to do some research. I want to do presentation to my professor at the Mayo Clinic. And he told me that's not the interesting subject. So
Wow.
it's really completely dismissed.
That is really sad,
Yeah,
considering.
so this needs to be changed, in my opinion. Medical education need to be changed. OBGYN and residency need to be changed. But anyway, I don't want to sidetrack too much about my opinion, but I think important patient need to find a true specialist. Because nowadays anybody can call specialist of endometriosis, even though they do not have any experience.
Right.
Experience is most important. I don't call them specialists if they are get out of the school or just starting in practice.
Okay.
You need to see endo case, hundreds, 1,000, 2,000, 2,000 cases, 3,000. More and more you experience endo, you really understand this complex disease. So it's important to find a true specialist who has lots of experience. And um, I'm sorry, what is the question again?
So what would it the first steps? Would it be blood work, scans?
Oh, yes. So find a great doctor, okay, who knows endo and who can listen to your symptom. And then it's important your doctor spend enough time with you, listening to all of your symptom, all of your history. Then he needs to do a very good detailed pelvic examination.
Hmm.
Then transvaginal ultrasound.
Hmm.
And I do my own ul- transvaginal ultrasound because of I do not trust radiologist.
Hmm.
And the reason why is so many patients went to radiologist done by ultrasound, they said completely normal pelvis,
Yes.
no evidence of endometriosis.
Yes.
Then when they come to see me, I do my own ultrasound, I find abnormality, something wrong with inside, which is not normal.
Yeah.
So I just cannot trust radiologist, number one. And also number two, you can do MRI, but negative MRI does not mean no endometriosis. Even though you have a completely normal MRI, so many patients has endometriosis.
Fascinating.
So these are the very important component. You need to find a great doctor who can listen to you, who can address your issue, and who has enough experience and also enough knowledge. They need to know endo
Yeah.
inside out.
Yeah. 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 And that
That's a key.
it is. Yeah. And that leads me to my next question about the work that you do, Dr. K. When endo is removed through the procedures that you're doing, through the surgeries that you're doing, what is the percentage or likelihood of it coming back again?
Yes, I have some statistics. I have done close to 6 to 7,000 excision cases in my life. So I am constantly improving my technique. So if you see me 20 years ago, my technique 20 years ago is much more immature, but I am refining new technique, more specific, precise method. So my latest number, this is a 5 year statistics after my haptic excision. For stage two, my recurrence rate is about 2%,
Uh-huh.
and stage three is about 5%.
Yeah.
And the stage four, my recurrence rate is now down to 12%.
Okay, wonderful. I guess it's good that people can be, confronted with those numbers and understand, because nothing can do what surgery does in the sense of going in and excising it, but nothing is guaranteed to prevent regrowth as well.
Right. Endo can come back, yes.
Yes, yes. Um, Look, we have some questions that people have put into the chat, and I'm thinking that we may just move on to these because there are some really wonderful questions that people
Yes.
put in. Um, Julie's asking, what if you had excision but done robotically? Does that cause more issues?
Yes, in my opinion, or I can speak. only from my personal experience because of I fixed so many of after the Da Vinci robot patient came to me, and they are okay first month or second month, but many of the patient they start to develop much more pain. And so when I enter inside, and I have a comparison picture before the Da Vinci, after the robot, and there's so much scar tissue, many different layers of scar tissue, which is developed by Da Vinci robot. And I think reason why is when your doctor uses Da Vinci robot using the Da Vinci scissors literally using electricity, uh, monopolar electricity cutting method.
Mhm.
So it is not really pure cutting, but it is like abrasion, like a burn and cut, burn and cut. So when you cut the endometriosis here,
Mhm.
then burning energy hit the endo, and actually endo splash,
Mhm.
then implanting in surrounding area. Then monopolar scissor is very extensively burning scissors, so they can stick together after the surgery. So every burning area they stick together and they create an adhesion, scar tissue. Not only one layer, but I saw 5 layers, 6 layers. So
Okay.
these are the one causing more uh, pain issue after the surgery. And so that is one reason I do not recommend Da Vinci robot. And another reason is robotic doctor cannot feel any tissue, no haptic in Da Vinci robot. So many of the Da Vinci patients, when I fix them, many of the deepest root of the endometriosis is completely intact. It's not even touched yet. So so these are the two major issues.
Okay. Well, that's really interesting. Thank you. Um, Look, if what preventative measures can you take for a young person to avoid endosurgery or at least to detect and diagnose earlier? And I think that goes back to the you answering the question before to really find someone who's a specialist,
Mhm,
do a thorough case history, good imaging.
mhm.
Yeah.
Yes, especially last week I have my 19 years old teenage patient. She has been suffering so many years, and she went to OB/GYN doctor, pediatricians. I think she been to more than 10 doctors, and none of them diagnosed endometriosis, and they just put her into continuous birth control pill and hormonal treatment. So just go around the bush
Yeah.
without really pinpointing diagnosis. Then she has so much pain, and also besides, even though she's taking birth control pill, she has been bleeding every single day, like the last 40 days.
She's been
So she
bleeding despite the pill. Yeah.
every day. And so she just doesn't have enough. She doesn't have any life basically. Then she came to me, and um, I was able to examine the abnormality inside her. So I did a laparoscopy recently, and she does have a stage 3 endo.
Okay.
So so her story is not unusual. I
No.
have another young patient. She's my youngest, 11 years old. She has a stage 3 endo. So
Wow.
teenager, we need to pay more attention to teenagers' pain. It
Absolutely.
is real. It is very painful, and endo can be developing so many areas.
Absolutely.
And so, so I was like before this chat room, I was watching her picture. So anyway, I just want to share, how high endo look like.
Oh,
Do you see
wow.
this?
So they look like
There's
little
so many
white
of them.
blisters.
Yes, this is very active, painful endometriosis. I wanna hide identity, but can you see this?
Yes.
This is only one area. And I counted a total of over 100 spots of endometriosis from her body.
Wow.
And there's no wonder she has so much pain.
Yeah. Yeah. So endo can really present itself so differently.
Yes, it
Yeah,
is.
yeah,
So
yeah,
this blister is a one kind of endometriosis blister type.
yeah.
And another type is, I can show you a couple of different patient picture, but this is more like a adenomyosis endometriosis.
It looks
You,
nasty.
you can see like how aggressively
Yeah,
invading, infiltrating. This is like this kind of endo behave like a cancer.
yeah,
It's like a benign cancer. So it's totally destroy tissue and they are very locally invasive.
yeah. Wow. Wow.
Right.
Yeah, and I think that it's also important to find somebody that has done that's done the cases to be able to identify because like you've just demonstrated, endo will present itself in so many
Mhm.
ways and colors and textures and layers. So yeah, that's great.
Yeah, because endo can happen in white color, pink, yellow, black, blue, and
Wow.
brown,
Yeah.
and it's like a rainbow, basically.
Wow. Wow. This is a question from somebody in the chat. Now, she's asking, do you find that robotic surgery puts patients' fertility at risk?
It can, it's possible because of if you develop ovarian chocolate cyst, endometrioma, uh, robot burns so much tissue, so it is very easy to destroy ovarian tissue and everything stuck together. I have already so many patients I fix their ovary is stuck to the pelvic sidewall.
Yeah.
And some of these picture I share in my Instagram post. And she has a completely normal right ovary, no scar tissue, no adhesion before surgery. And after the robotic surgery, uh, her ovary is stuck
So,
like this on the sidewall, and ovary is immobile.
okay.
And the fallopian tube is also stuck together.
Okay.
So, so these are the some of the example. Da Vinci robot uh, can be dangerous to decrease the fertility chance. So it is important to find that surgeon with good skill, good technique, and no burning technique.
Yeah. 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 Um,
No burning.
yes. Yes. No burning. So someone's asking if you had misdiagnosed endo for a long time, 14 years, finally got
Right.
diagnosed, DIE, stage 4, now has extremely low ovarian reserve. Is there anything you can do at this point to optimize fertility? She also has adeno.
How old is she?
I know that's a big thing. Like
Oh,
all,
she doesn't know. Okay.
yeah. Obviously age is going to impact. Hang on, has she replied?
Mhm.
41. 41. Yeah.
Uh,
I'm so sorry.
41. Okay. Um, it is possible because from my experience, endometriosis is very toxic. They make your body toxic.
Mhm.
So endo patient, their pelvis, their pelvic cavity is so baby unfriendly, anti anti-pregnancy, causing the infertility environment because of a toxic effect of endometriosis.
Yeah, it's
So
chronic in
even she is 40, also adenomyosis too. Adenomyosis also causes the same type of effect.
Mhm.
So even though she's 41, I don't give up.
Mm,
And there's hope because of I operated on the patient. She's in her early 40s, probably similar age as she is, and the low ovarian reserve by AMH.
mm.
And she's almost giving up. But after I clean up endometriosis, some of the adenomyosis, DIE, same type of situation, her number of AMH much improved.
That's
And
wonderful.
so I have another patient. This is not a DIE patient. She's a Japanese patient. She's age of 45 or 46 when I operated on her. She has stage 3 endometriosis, and there's no her husband is younger age, but not much younger. And she was 40, I believe 46, I operated. Then I remove all of endometriosis and her tube is open and she become pregnant in 1 month after my surgery, and she delivered a baby at the age of 47.
Wow. Wow.
Yeah.
Um,
So miracle happens. I'm seeing many miracles in my life.
wow.
So don't give up.
Yeah.
Please don't give up. Find the right doctor. Find a doctor who knows endo. Find a doctor who has skill,
Yes. And I just want to
who
add,
has good hand.
yes, and I just want to add from a naturopathic perspective, there's plenty that we do to from diet, lifestyle, herbal medicine, nutritional medicine to really calm down that chronic inflammatory pelvic environment. And as Dr. K mentioned earlier, the pelvic environment in endometriosis is anti-baby, anti-pregnancy. There's constant inflammation in there from the endometriosis and the processes that have taken place. So
Yes.
that's where you want to work on your immune system and dampen that immune activation. So definitely get a good team around you. And whether or not you end up going down the path of like IVF or ICSI or whatever it is, all these things will not go to waste. Getting the right surgery, working on diet, lifestyle, nutrition, etc.
Mm-hmm.
All going to help,
Mm-hmm.
especially for
Mm-hmm.
antenatal postpartum, because in my practice, I don't just want to get the patient pregnant. I want to encourage a healthy pregnancy, healthy baby,
Yes.
healthy mom postpartum too, because your health is so important also to look after that baby. Um, Wonderful. So we've got a question. If you've had multiple surgeries in the past, do you believe in another surgery is a better option before attempting fertility treatment, or less is better?
That question need to be individualized, and that depends on what kind of multiple surgery patient receive. If patient have a 3 abrasion before, then I would say
No.
her endo is not even touched.
Yeah.
Her endo root is still there,
Yeah.
so she's still suffering from effect of endometriosis, and plus more scar tissue adhesions caused by the abrasion burning surgery. So, and also if she's a good age, good ovary, then it's much better to clean up correct way
Yeah.
to get to the root of the disease
Yeah.
than to remove endo tree,
Yes.
pluck this out from your body from the root, then her body become completely detoxified from
Mm,
the effect of endometriosis.
yes.
Then she, she will become much more easy to become pregnant after endo is gone.
Yeah.
And also, light surgery, for example, when I do my excision surgery, I don't use any energy. My cut is completely cold cut.
No
I don't burn
electricity.
the tissue. No electricity, no burning, just cut only.
Yeah.
Then this is the type of way you can minimize scar tissue after surgery. And also, I do treat not only I excise endometriosis, I excise the scar tissue.
Mm,
So doctor can, if this is scar tissue, doctor can just cut the scar tissue between. Then he say, okay, I release the scar tissue. That is not enough.
mm,
Reason why scar tissue is developing is this tissue is so sticky already.
yeah.
This tissue is toxic. So just cutting a band is not really treatment of scar tissue, but I do cut all of this scar tissue already affected abnormal tissue from her body, so they don't stick together.
Yeah. Yeah. Makes complete sense. Wonderful, thank you. Um, Someone's just been diagnosed with adenomyosis via MRI, and a hysterectomy
Mhm.
has been recommended. She has all kinds of symptoms related to endo for 20 plus years. If I have my uterus and ovaries removed, will my endometriosis stop causing me problems and symptoms? I'll say no. What is
No.
the benefit or reason for me to explore surgical options to remove the organs and any endometriosis?
Um, First of all, endometriosis, I repeat again, I already mentioned before, but endometriosis is not same as endometrial lining of the uterus.
Yeah,
They are not exactly same tissue.
yeah.
And so by removing the uterus, it's not going to cure endometriosis. And um, by removing the ovary, it's not going to stop endometriosis. So if people ask me what causes endometriosis, why endometriosis happen, uh, my answer is I don't know. It is so complex, so complicated. It's multifactorial. Endo is such a complex disease. You cannot put into a couple of sentences.
Mhm.
And so again, I repeat again, endometriosis produces its own estrogen, and endometriosis is locally invasive and destructive. So removing the organ is not the answer.
Yeah,
I
yeah.
don't know. Do you understand me, Kimberly?
Oh, and I have patients who have had hysterectomies without endometriosis excision surgery, and I think it is criminal.
Yeah, it's not necessary. And
No,
that's not to address the endometriosis. Endometriosis need to be addressed individually, one by one, which is located outside of uterus.
yes. Yep,
And so by removing the uterus out and does not treat each one of the tiny detail of endometriosis, patient is still suffering the same symptom
100%. And I just
after surgery.
and I just want to add a hysterectomy isn't always necessary for adeno either. I mean, Dr. K, you are, I think, one of the only surgeons I know that does an adeno excision, where you
Yes.
literally excise diffuse adeno from uterine tissue, and that is something that I think patients need to understand too, that it's not always necessary to get that hysterectomy.
Mhm. Right. And I want everybody uh, everybody needs to know diffuse adenomyosis is not a death sentence. To only verdict is hysterectomy. That's not true anymore. You can save your even very severe. I save adenomyosis almost like a 6 month size pregnancy size.
Yeah,
And I cut that 280 pieces and I put over 100 stitches. But in the end of this very hardworking surgery, this is so delicate, so difficult to do, but it is still possible. I saved her uterus, then she became pregnant.
yeah,
So you have a choice. So please don't listen to your doctor say adenomyosis, only hysterectomy. You don't have any other option or medical treatment. Suppress the period or whatever, but birth control pill or some more stronger hormonal medication. There's another treatment you can save uterus from adenomyosis. Then you can improve from your adeno symptom and you can have a choice to become pregnant in the future.
yeah. Um, it's interesting that you say it's not the only choice anymore. When I had my excision surgery 13 years ago and I came out of that surgery, my surgeon said,
Mhm.
look, you have a very bulky uterus, which is the telltale sign of adeno, right? And
Yes,
these days I have a very normal uterus. So thank God I don't have a classic
that's
bulky
great.
anymore, adenomyotic uterus anymore. And I've had three babies. But yeah, back then he said, look, if you do want to deal with it, then the only way we could deal with it is via hysterectomy. That was 13 years ago.
Right.
I'm so glad to see things have changed. So it's very, very encouraging for adeno patients. Um, do you know what the link is between endo and ovarian cancer, Dr. K?
Um, Chance of endo patient to develop ovarian cancer is less than 1%. So, so it is very small percentage. But ovarian cancer can develop from endometriosis, like a chocolate cyst, endometriosis origin of the ovarian cancer type is happening, but it's very small, like a 99 point some percentage is a benign disease.
So would you say that removing the chocolate cyst would mitigate and lessen that risk?
Oh, I see. Mm,
Would
I
not,
cannot say that much because of there's any there's some statistical association data. So it's not like endometriosis cause and effect causing ovarian cancer. So uh, so I think removing the chocolate cyst is also important for the future.
Yeah,
Um, so removing the disease, making your ovary more healthy environment.
yeah, yeah, yeah. Okay. Um, when trying for pregnancy after surgery, do your patients usually conceive naturally or via like IUI or IVF?
My statistics wise, uh, depends on the stage of endometriosis. Early stage endometriosis, pretty much like almost 100% of my patients become naturally pregnant.
That's so good. I love that.
Yes, and but even stage four endo and stage three, 80% of my patients become pregnant naturally after my surgery.
That's
No
wonderful.
IVF, no IUI.
Yeah.
But some patients require IVF, IUI, depends on the patient.
Yeah. And
Right.
that for me is so encouraging to and goes to show how much our bodies are wired for fertility. Like our body,
Mhm.
that's I mean, our reproductive system is to reproduce. So when
And
the store
I
anatomy,
think yeah, one of the I'm sorry, I don't mean to cut you off. Uh, one of the reasons why high success rate of natural pregnancy uh, after my surgery is because of I'm pretty much determined. I have a determination to go after even one tiny pinpoint size of endometriosis
okay.
to be excised without any burning from her body.
Yes.
So, I do very super meticulous approach. Even one tiny point of endo, I will remove excise. And uh, so this makes big difference because even though if you do some excision surgery, uh, you remove endometriosis, most of the major endometriosis, but the really pinpointed size endometriosis left all over there, then I think natural pregnancy rate is not, can be compromised. So
Yeah.
it is very important to meticulously remove all of endometriosis from the patient's body.
Yes. Yes. Now, is there ever a time that ablation is okay, say on the uterosacral ligament?
Uh, I don't recommend ablation on the uterosacral ligament. You can, especially there's a very crazy procedure called uterosacral ligament ablation, and so I think that's in my opinion that's very barbarian practice. I don't recommend to anybody. I think it can cause even more pain.
Yeah.
So, so endometriosis located on the uterosacral ligament, it need to be precisely cut
Mm.
by haptic technique without any burning.
Yeah.
So just the endometriosis is removed, and normal component, normal tissue of uterosacral ligament need to be completely resolved for the patient feel better.
I had a lot of endo on that topic. I had a lot of endo on my both of my uterosacral ligaments. I'm so grateful it was excised properly. I have a patient who had lots of endo on her uterosacral ligament too, and her surgeon literally cut the entire ligament off. And she was,
Wow.
yeah, it was really, really heartbreaking. I had to, go through the reports a couple times to just double and triple check and confirm with the surgeon. But he did. So I don't know what's worse, like ablation or not being able to, because what you're describing is it's a meticulous process, right? And it's a sensitive area as all of the reproductive tissue is, but yeah, we
Yeah,
all
like for example, I
sort
find a picture of uterosacral ligament endometriosis, which
yeah.
is, can you see me? It's right here.
Oh yeah.
And this is my scissor. And there's no burning. Uterosacral ligament goes here. See, like I am touching this endo tissue, and I am meticulously finding a plane to differentiate normal and endo and the cutting between to release this endometriosis off from uterosacral ligament. And
Yeah.
so this is a very delicate, touchy, feeling procedure, not only visually, but my hand is feeling at the same time.
Yeah. So
So I can, yeah.
sorry, if someone
So
was
I
to
can,
ablate that,
mhm.
I was just looking at your picture again. So if someone was to ablate that, they would leave all the roots underneath that. So
Yes,
um
yes, exactly.
yeah, Courtney, to answer your question, personally, I would say no, no.
No.
Just because, it could come back worse and more intense also with ablation. We know that. Um, Question for you, Dr. K. What are the scars and excision points like when using haptic?
Can you clarify the question? What is,
I think she's asking about like the cuts that you make on the abdomen. Like, is that what you're can you please just clarify? Or I also have a question about that. So when you're cutting out the lesions internally, so let's say
right?
that uterosacral ligament, what, because you'd be left with like holes from where you cut out the endo, right? So what happens to the
Mhm.
tissue? Does it eventually just heal back together where there are these holes that you've cut out the lesions from?
Oh, yes, yes. So I don't put any stitch. So I slice the endometriosis, and so this is a normal tissue left.
Yeah,
And then after that, tissue going to regrow, reperitonealize layer by layer, and it's going to be healed.
yeah, yeah.
Is
Um,
that the question?
I'm not sure, but I think she's also asking about the points on the belly, like on the belly that you cut through. I had haptic and they're teeny tiny, they're like less than a centimeter. And I'm sure yours
Right.
would be tiny too.
Oh, she's talking about the incision line.
Yeah, I think so.
Okay. Yeah, I do make a 5 millimeter incision line
Okay.
inside the belly button here. Okay, just 5 millimeter. Then I'm gonna make a two more incision line right next to my pubic hairline,
Yeah.
another 5 millimeter each. So, so my patient have a three small incision line.
Okay.
5 millimeter, 5 millimeter, and 5 millimeter.
Interesting. I have,
Yeah. If you use Da Vinci robot, they make the five incision line, and it's a bigger incision line and more higher, like a belly button and here, 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 instead of down.
uh,
And they make three times more incision line than my laparoscopy. So my haptic incision line is 15 millimeter, combines three incision line. Da
yeah.
Vinci robot is 45 millimeter instead of 15. Mine.
Okay. Wow, interesting. Um, Question, if a woman with DIE endo is in perimenopause, do you recommend hormone therapy in the form of estrogen and progesterone to aid them in conceiving?
Uh,
Do you deal with fertility too, Dr. K, or do you solely just deal with the surgical aspect of it?
uh, I I am mainly I'm an excision surgeon, but I do taking care of more entire, like a whole person of my
Yes.
patient. And so each one of them, I also recommend the diet, lifestyle change,
Yep.
and also stress reductions.
Yep.
Uh, Meditation is also important. And so patient need to be treated as a whole person, not only excision only. So that's the reason why I like to follow up my patient after my surgery every 6 months, once a year, because of I want to keep track of my patient if endometriosis is coming back or something else is going on. So, but anyway, to answer your question, in the menopause patient, I am seeing quite few menopause patients develop endometriosis. So recently, I have a 65 or 66 years old patient. She
Wow.
developed stage 3 endometriosis.
Post-meno.
Postmenopause, yes. So menopause is not immune to the endometriosis, and it's very important. You know, uh, you need to be checked after menopause.
But Dr. K, on that topic, is it um would you say that she's developed it postmenopause or that it's been asymptomatic for most of her life and has presented itself during this season?
Oh, that's good question, but I don't know because I haven't really operated on her before in the reproductive years, only after the menopause.
Yeah.
But there's a significant amount of endometriosis, and some of them looks very active endo. I think producing estrogen locally.
Wow, it's fascinating. Um, I'd love to see a hormone
But
panel.
I know the difference between endometriosis postmenopause, which is totally inactive.
Yes,
They look different. But the active endometriosis, I can tell. And
yeah,
she does have a many active stage 3 endometriosis popping up. So I really believe this is going to be happening recently. Not like 40 years ago, 50 years ago.
yes, it's fascinating. And it would be interesting to know if she was on HRT through perimenopause. Um, just my
She's not
thought.
HRT, no.
All right. If you remove all the endometriosis, can hormone therapy make endometriosis grow back?
What kind of hormone therapy
Yeah,
she's talking
not
about?
not very clear. Um,
IVF
yeah,
or
yeah,
egg
because we know
retrieval?
we know that, during fertility treatment, hormones stimulate and
It's very strong, yes.
yeah.
So for IVF, egg retrieval, if you have endometriosis, they will make your endo much worse.
Oh yeah. And I have a
Yeah.
friend who's actually a practitioner practicing similarly like myself, and she was going through an IVF um journey post stage 4 DIE excision, haptic excision, doing IVF. And even then, she was testing her estrogen levels, and it's just insane how high these meds stimulate you.
Mhm.
It's out of off the Richter, off the
It's
chart.
it's like a, it's like how to say in English? IVF egg retrieval medication is literally put in a you know
It's like
bucket of oil,
turbocharging. Yeah,
to the fire.
yeah, yeah,
So
turbocharged.
you're already burning inside from endo inflammation. You literally stimulate so much,
Yeah,
and endo become very happy. They grow like a crazy.
yeah. It's really, really like it's so important to get it removed if you can before
Right.
doing
So
IVF.
it's much better if you want to become pregnant, or if you are thinking about IVF, it's much better to clean up your endo
Yeah,
first before IVF. Then maybe after completely clean up, you don't maybe even need IVF, like 80% of my patient.
yeah,
You can save IVF, or if you need IVF, but your endo is gone, so your IVF is much more successful.
yes, exactly.
Implantation rate is much higher without endo.
Yes,
And so either way, you can get a win-win.
yeah. Someone just saying you're so right about endo being dismissed. I've been on a long journey to find doctors who are willing to help me. Even my husband is a doctor and he even doubts me. Oh my goodness, that's a tough place to be, Rebecca. I'm sorry to hear that.
Sorry.
Yeah, Julie, it took me 14 years of multiple doctor consults across this country. Oh, they're referring to when you were talking about how difficult it is because doctors don't really get taught. It took me 14 years of multiple doctor consults across this country, and every single symptom of mine was dismissed, and an absolute emergency is what landed me in the hospital. Very, very sad. Um,
Mhm.
Ivana's just asking, what can you do to prepare before an endo excision surgery to help recovery be better or smoother? I do a lot of that stuff, but I'm just interested to hear about is there anything that you advise your patients from a purely medical and surgical viewpoint, Dr. K?
Depends on the history of each patient again.
Mm-hmm.
So so I need to be individualized. But there's hmm, I need to know more each patient's situation,
Yeah.
like what kind of medications he's taking, what kind of pre-existing conditions, other medical disease.
Yeah.
So I need to know the history.
Yeah, exactly.
So there's no one sentence formula, uh, but I gonna individualize.
Yes. Yeah.
And but the preparation wise, my preparation is pretty much very simple. And so um, patient can come to the hospital in the morning, and of course, nothing to eat or drink after midnight. And um, I'm gonna go over the medication list and what kind of medication need to be stopped before the surgery, and what kind of medication can be started right after the surgery. So, all of these pre-op consultation is necessary
Yeah. Yeah.
to maximize the outcome. Yes.
Yes. And just regarding that topic with my work that I do, we look specifically at tissue repair and healing and nutrients that help with collagen production, antioxidants,
Hmm.
anti-inflammatory foods, foods that are really easy to digest on your easy to absorb. So we want to
Yes.
not use up too much energy breaking down and digesting food, but warm foods, easy to digest, good sources of protein, fiber, so that you don't want to be constipated after. Oh my goodness, I remember my first bowel movement after excision surgery. It was terrifying. So you don't want to be constipated. So all that stuff is more the work that I do, and then of course Dr. K, your
Hmm. Yeah, this is more Kimberly's area. Yes,
yeah,
your specialty. Yes.
yeah. So that's what
Yeah.
I do. Okay. Question. This is an
And I do recommend matcha green tea,
yes,
and
love
to
matcha.
all endo patient.
Very, very high antioxidant and helps with
Yes,
effective estrogen detoxification specifically.
yes. And
Favor,
also matcha green tea help you to relax,
yes,
for the mind-wise.
yes. So
So it's good for your brain, and antioxidant, anti-inflammatory, anti-endometriosis, also anti-aging too. You
yeah,
look younger.
antioxidants. So it is green tea leaves contains L-theanine. So theanine is
Yes,
it acts on your neurotransmitters, specifically GABA, which helps you feel more cool and calm and focused. So totally different to coffee and caffeine. Your matcha green tea has the effect of
right. No jitteriness like a coffee.
yeah.
So it's very smooth, like a awakefulness. Yeah.
Yes. So good cognitive focus, not that crash from the
Mhm.
caffeine in coffee.
Yeah, that's why I take matcha green tea before my surgery.
Oh, that's so good. That's so good to
Yeah,
see. I know you love it and you recommend it to patients.
my matcha tea ceremony time. Then I meditate, I
Ye-
focus, and I meditate upon my next patient.
ye-
Then I'm gonna strategize how to go after the endometriosis.
Yes, that's wonderful. I love hearing that. It's like the doctor needs to look after himself too, so that he can look after
Yes.
us. This is an interesting case. So if a patient has three ectopic pregnancies as a result of scar tissue from two Da Vinci surgeries and
Mm,
three laparoscopies for ectopics, would you recommend the patient have surgery again with you and then try to become pregnant? What's the connection between endo and ectopics? Oh, that's interesting. So three ectopic pregnancies as a result of scar tissue from two Da Vinci surgeries. So three ectopics mean three additional laparoscopies, and then Da Vinci's prior causing that scar tissue.
hmm. Okay. And she wants to become pregnant. That's her number one goal.
Yeah.
Also, she has a symptom of endometriosis, pelvic pain,
Well,
any other
yeah,
symptoms.
she's not saying that, but she said, what's the connection with endo and ectopic? Would you recommend that she has surgery with you and then tries to become pregnant?
Yeah, there is a connection between endometriosis and ectopic. Endometriosis is like again, I repeat again, but a highly inflammatory state. Endometriosis causes inflammation, and endometriosis causes scar tissue. So uh, recently, I operated on my patient last week. She had so much scar tissue, endocaused scar tissue, around her fallopian tube. She
Mhm.
didn't have a history of ectopic pregnancy, but if she's not uh, treated, continue like this way, then her fallopian tube is literally twisted like a zigzag form
So the egg's
and not even
way
straight.
down. Yeah. Yeah.
And so I have to go inside. I have to release all of the scar tissue around the fallopian tube. And just one fallopian tube, I find 25 spots of endometriosis in one fallopian tube.
Wow. That is a
So I cut the endometriosis from fallopian tube, its own scar tissue. Then in the end, her tube becomes straight.
Mhm.
Then I make sure her tube is open. So I push the blue dye study and push all of the debris from the fallopian tube to help her to become pregnant. So these are the type of treatment we can try and to help the patient to become pregnant and preventing uh, further evidence of ectopic pregnancy by the endometriosis.
Yeah. Yeah. So yeah, I'm sorry to hear that you've had this experience, but yeah, so the connection is that literally, endo can cause blockages and your fertilized egg is implanting in the wrong place due to structural blockages, potentially from the end.
Right.
So yeah.
Um, I can, let me see, I can find the picture or not. I can show you. Uh, I have so many pictures.
It's
Okay.
so good
Yeah,
that you take all these photos for your patients. It's so fascinating to see.
yeah. I usually take 50 to 100 picture each one of my surgery,
Mhm.
and I give to my patient. Let me see if I can find a good example so you can understand me. Ta, ta, ta. Yeah, I'm sorry, it's longer than.
That's okay.
Yeah,
Just seeing, I know we have to
yeah.
wrap up.
This is one of the endometriosis located on the next to the fallopian tube. This is a uh, deep nodular, one of them.
Yeah.
But oh, so this scar tissue is caused by the endometriosis. This type of scar tissue. It's not by the surgery, but the endo scar tissue.
Okay. So you can
And this one too. This one too.
differentiate between scar tissue caused by endo and scar tissue caused by previous surgery.
Yes, I can. Yes. And see, this is a fallopian tube. Look at this tube, fimbria end,
Hmm.
and look at this scar tissue around the fimbria. You cannot even see the fallopian tube structure. It's all buried inside.
Well,
Yeah. So so it's really endo is like a big monster, if you get to this level. Um, so this is a fallopian tube. I'm operating on the fallopian tube. Look at this fallopian tube. This is all covered by the endometriosis. Not only one layer, three different layers.
wow. That
So
looks,
all of this needs to be completely released for the patient to get better. Like, hmm, let's see. Yeah, yeah. This is endometriosis cause scar tissue.
oh, wow.
Can you see this? This is fallopian tube. This is ovary. This is a scar tissue between fallopian tube and ovary. Can you see this?
Yes, yes, I can see it.
Yeah.
It looks absolutely like, yeah, just it's beyond me. Endo is just, yeah, like you say, it's a monster,
So
It's so
please
many different.
understand, excision surgery is not just the excision. If you find a true endo specialist, really good doctor, he or she knows not only excise endometriosis, but a good surgery means they need to repair your inside. They need to restore. Endometriosis causes chaos, pure chaos inside your body. But a good surgeon can get into inside, stop the chaos, remove the endo, put back the order to your body.
Restore.
That's true definition of excision.
Yeah, yeah. Um,
So it needs to be restorative. Restoration is necessary. You need to restore your body.
yes, restore the normal anatomy.
Normal anatomy, yes.
And on that topic, someone's just asked, how does she know if endo is coming back or if an area was missed?
How do I know? Oh, you're talking about after a surgery
Yeah,
patient?
yeah. Yeah.
Yeah, if I need to go back to the surgery for the second time, because I took so many pictures of my detailed record, I can tell each area how I exercise.
Yeah.
And each area how I get down to the root of the disease. So once I go back inside, then I can put my, camera scope and I put my laparoscopic camera almost this level of closeness, almost like a near touch.
Hmm.
I'm almost close to touching level. And I can see like a detailed picture of endometriosis and which is new endo, or I can tell by examining this.
Right. Yeah.
There's
So
a difference.
from a patient's perspective, how would she know? Would it be just purely based on symptoms?
Oh, that's a good question. Patient is very patient is very honest and very smart. They know endometriosis symptom.
Hmm.
So if endometriosis come back, you have a memory of endometriosis,
Hmm.
pain and episode, from before, and you can tell. And also, we examine the patient, then I can see, you know, new chocolate cyst is developing, no new anatomical change, abnormal ultrasound exam, abnormal pelvic exam, and we can detect new endometriosis is coming back.
Yeah. Yeah. Um, I
So
have
I look at the complete big picture, history, and the physical exam, and my own exam, and to decide which patient is endo is coming back.
yeah. Yeah. Okay. Um, and how would a patient know if endo has been missed? Is that something that would be able to, like, I don't even know how to answer that question. There would be no change in a certain area, or symptoms wouldn't have shifted that much post-surgery.
Um, okay. Yes. One of the good example is you have a surgery, e- even excision surgery, then you do okay, 1 month post-op, 2 months post-op, then 3, 4, 5 months post-op, endometriosis pain is going up like this, and suddenly even become more endo symptom than before the surgery,
Mm,
and that is most likely sign of a deep root of endometriosis is completely missed.
okay, that's really, really interesting. And I do want to ask a question because I have a case who we potentially think may have been had endo missed, and I've never heard of a doctor recommending post-op cortisone shots
Mm.
locally to into the pelvis. Is that something that is common? Is that something you've ever practiced? I mean, what are your thoughts on that?
No, I don't believe in that. Um, it's much better to let your own body, ne, your own body healing take its own place.
No, I'm meaning post-op pain and using cortisone shots post-op.
Oh,
Look
the postal
at
pain.
areas. Yeah.
Mm,
To me, that's a red flag of potentially surgery not.
yeah, to me, that is too much manipulation and unnecessary. um, it's, it's, I just don't like it. I don't have any scientific data, but
Yeah.
that's not my practice.
Yeah. Okay.
Yeah.
Um,
I
okay.
would rather let on human body take its own course with minimum intervention and let nature take its own course of the healing process after my surgery.
Yeah. Yeah. Dr. K, I know you have a long history in obstetrics. Do you know if there's a link between uh, preeclampsia and endo?
Oh my gosh, I have not done obstetrics for so many years.
That's all right. That's all right. I'll have to
It's
look
back
into
in
it.
my residency time in Mayo Clinic.
Yeah, I'll have to look
But
into the research.
um, that area, yes, there's some connection. But I don't really study the preeclampsia anymore. So uh, There's some, I do believe there's some statistical association, but sorry, I don't have enough knowledge to tell you
That's
preeclampsia right now.
That's okay. We have to wrap this up in a few minutes, and I just want to pull out a couple of last good questions. So let's say someone is thinking they may have varicose veins in the pelvis and pelvic congestion syndrome. Would you recommend them dealing with that with a vascular specialist first before attempting a laparoscopic, she's asking an exploration surgery?
Mhm. Um, Good questions. There is a pelvic vein congestion syndrome treatment by the radiologist.
Yep.
So they literally put in a coil
Yeah.
into the pelvic vein by interventional radiology. And I look at the data, and the data is kind of like a mix. Sometimes it works so well, but some patient, it doesn't work well. It is causing even more pelvic pain and not necessarily so successful. So if if patient is all suspecting endometriosis, also pelvic pain congestion syndrome, I think it's important to rule out endometriosis pain because of they can overlap.
Yes, absolutely.
So, so if I consult in that kind of patient, of course each patient needs to be individualized. But I want to clean up all of the endometriosis first
Hmm.
because of pelvic vein congestion syndrome. Treatment can be quite invasive.
Yeah.
So if endo is completely gone, uh, everything is treated, still having a same type of symptom, then I think she can try to use the pelvic vein congestion treatment.
That's so interesting. Yeah, because if you think about the anatomy and like the ovarian veins and the gonadal veins, are you operating close to and around all of that?
Yeah, right there. Yes.
Yeah.
So many times I find the endometriosis in the infundibulous pelvic ligament area that is underground is ovarian vein and
Yeah.
ovarian artery.
Yeah.
And that is a vascular structure causing pelvic vein syndrome. But I'm seeing many patients who develop pelvic vein congestion syndrome and endometriosis in the same area.
Yes, and I've just been diagnosed with that. Funnily
Oh,
enough,
wow.
I have severe varicose veins all the way down from my renal veins all the way down to the basket of veins around my ovaries. So I'm going to be getting an embolization eventually, hopefully soon.
Wow.
But yes, I agree with you in getting the endo cleaned up first, to ensure that that's, because the embolization is irritating the veins, literally
Right.
kill them off. They inject it's almost like a glue to irritate the vein to shut them down. So yes, Courtney,
Mhm.
probably better doing the lap for endo first and then seeing how your
Then
symptoms.
by doing a laparoscopy, you can find how much pelvic vein is congested. You can see it by the
Mm,
laparoscopy during the endo-excision surgery. So you can kind of document for the radiologist, you can give picture to the radiologist so he can see, how severe pelvic vein congestion is.
very, very interesting. Yeah, so we do have a lot of questions, and yes, you will get this recording. You're so welcome. I do have a last question for you. Is it possible? Is there a way to find good haptic endosurgeons, Dr. K?
That's very good questions. Um, so this is just my personal opinion. So, you know, uh, so you can listen to me, my opinion wise. The haptic excision is really the mainstream of endometriosis excision long time ago. Before Da Vinci robot comes, if your surgeon is uh, endo excision surgeon, then they must be haptic because they are holding an instrument and they are cutting the scissors. Surgeon is holding the scissors and the cutting. So surgeon can feel the texture of the disease. So whole process is haptic.
Hmm.
So, so I don't even need to invent terminology of haptic before if you meet me 20 years ago. before robot because it is so natural, intuitive to use haptic techniques to exercise endometriosis. That's the only way to work.
Mm,
Then, then Da Vinci robot came into the picture, 2002. Then all the surgeon, jump into Da Vinci robot, and it can be trendy or new technology, and then I can start to see, oh my gosh, this surgeon is operating no haptic.
mm,
So, so that's why, in order to describe my surgery, is totally different from Da Vinci robot. I introduced terminology of haptic excisions,
mm.
and so I think you need to ask the surgeon individually. And of course, if your surgeon is using Da Vinci robot, there's no haptic in Da Vinci robot. They are telling that there's new Da Vinci robot having some kind of, like a horse tension surgeon can feel, but this touch sense is much more delicate.
Mm.
So true haptic is really uh, coming from your own hand. So, so I think you need to interview surgeon by surgeon, interview them, then then you also need to study, you need to educate yourself. So that's why I created my own Instagram, not to recruit a patient but to try to teach people about the detail difference. So
Yeah.
this detail difference is so important. So I want patient to be educated. That's my number one goal of endo awareness month. And
Mm.
I want every endo sister knows every detail so they can choose wisely, uh, you know, best surgeon for their endo excisions without causing any issue. And I want you to become really well after the surgery. So I'm not really directly answering to your question because I don't have a list of haptic surgeon in the world. Uh, but I think you educate yourself, you ask detailed question, you can tell this surgeon is haptic, this surgeon is not haptic, very easily. And
Yeah.
also ask about the experience.
Mm.
Um, Good surgeon needs lots of endo experience. So if surgeon is just graduated from the school, I don't call them experienced surgeons.
Mhm.
It needs to be done thousands of surgery successfully to master endo excisions.
Yes.
So So I'm sorry, I'm not directly answering to your questions, but these are the very important point to interview a surgeon because you can literally trust your own body to, to operate it by him or her. So it is very important you know your surgeon's technique.
Yes. And
If they use burning technique, burning scissor, or cold cut, haptic or no haptic, use robot or no robot. These are the all important questions.
yes, and we need to clarify that just because they're not using a Da Vinci doesn't mean they're using a good haptic technique either.
Haptic, right, exactly.
Makes it more
For
complex.
example, like when surgeon is using a laser, carbon dioxide laser beam to cut the endo, and that is not haptic. Even though that's not Da Vinci robot, laparoscopic, but the laser beam hit the endometriosis and the cutting around the endo. But the surgeon is not still feeling the tissue.
Mm,
So he can kind of excise more superficially, but the deep endometriosis can be missed inside.
yeah.
So I am seeing that kind of patient too, not only fixing a Da Vinci robot patient, but fixing after the laparoscopic excision patient too. So haptic is a key, yeah, for surgeon to master this.
Yes, it's such a wild space to try and navigate as an endo patient, Dr. K. So thank you so much for your time and for your generosity and your knowledge in sharing this with everybody. Everybody's saying their thank yous in the comments.
Thank you.
Um, this will be sent out to everyone on replay so that you can have a listen and refer back to it when and if you need. So, thank you so much for joining us. You're so welcome, everybody. I'm so pleased that you were able to make it live and get the most out of it. And yeah, happy March,
Yeah,
happy Endometriosis Awareness Month.
Yes, thank you, Kimberly, for hosting this event. And thank you, every endo sister, endo patient listening to this live. We care for you, and we are praying for you, and we wish you the best. Find the best treatment, best doctor, best outcome, and I really wish you everybody happy endo awareness month, and please spread awareness this month, and please help each other.
Thank
Thank
you.
you so much.
Thank you. Thank you, Dr. K, and everybody. Have a really good night. Take care.
Yes. Good night.
Bye.